So we're joined today with Dr. Megan Berkenstock. Welcome.
Thank you.
So as Assistant Professor of Ophthalmology at Johns Hopkins Wilmer Eye Institute, could you tell us a little bit first about, your day-to-day, how life has been during these crazy months here of the pandemic?
Sure. So initially when the numbers of COVID positive patients were rising, we had pared down our clinics to seeing only emergency patients. And so I still continue to work 3 days a week. However, we slowly ramped back up from seeing only several patients a day, irrespective of the clinic we were in, all the way back now up to 75, almost to 100% capacity. And so it's been a little bit of a transition as both policies and patient perceptions on returning for medical care have changed.
Mm-hmm. Oh, absolutely. And I know to that end, you've recently submitted 2 articles for consideration for a journal publication. And if it's okay with you, I would love to talk a little bit about those. I know one was in regard to the changes in patient diagnosis and the visits by numbers of specialty in the 6 weeks before and after COVID. And this was in regard to specifically looking at the ICD-10 codes, correct?
Mm-hmm.
Could you talk a little bit, what kind of brought about this idea to do this study? And could you talk a little bit about that on a very high level?
Sure. So when we were seeing emergency patients only, we had noticed, at least in some of the satellite clinics, that more patients with herpes zoster had been presenting. Now, whether or not that truly was more patients with zoster versus just those are the patients that felt that their condition was severe enough to warrant coming in, was the source of, well, is this true or not? And so that's why we started to look at all the ICD-9 codes, 10 codes, prior to and after COVID to see if that truly was the case for all diagnoses. And that was also analyzed by division as well throughout Wilmer.
Mm-hmm. Okay. And so I guess we kind of take a deeper dive in terms of the ICD-10 codes themselves and maybe look at some of the by specialty, like what you found by this certain specialties, like what went up and what went down, and was it what you expected to see?
Sure. Yeah, we the departments that remained very active were the retina department, and they still had a lot of codes suggesting intravitreal injections. We did not look at CPT codes to see if they truly were associated with injections, but the patients who were presenting had macular edema secondary to diabetes or retinal vein occlusions, in addition to wet macular degeneration patients. Similarly, the glaucoma service remained very active with all types of glaucoma, which were significantly we found more post-COVID. The ocular inflammation or uveitis division, which I am part of, also remained active, and some of the other subspecialties did decrease, such as low vision, and also the comprehensive eye service, which is mostly resident-based as well.
Mm-hmm. Okay. And how did telehealth factor into this as well? Because obviously a lot of patients were not coming in for in-person visits. How did you kind of factor that into your equation as well as part of the protocol?
Sure. So we looked at the number of telehealth visits, which increased 4-fold in the weeks post-COVID to allow us to continue to provide patient care, but in a setting that was, as we've understood from a lot of patients, a little safer for them or more accessible.
Mm-hmm. Okay. And as you were reviewing the ICD-10 codes and the findings, were there any surprises or changes that you didn't expect to see, or maybe you did expect to see?
I think the one that we really expected to see, and it definitely was there, was the diabetic eye exams had decreased, and also the number of cataract evaluations, all of which are, for the most part, unless there is a complication from those conditions, they are elective procedures. So we expected to see a decrease in that. And then we also did see an increase in herpes ophthalmicus or other herpetic eye diseases as well. And that was a little surprising. but can't really place my finger on that. But we did see an increase more post-COVID.
Mhm. Okay. And it sounds like one area that had an increase in codes was ocular trauma. Do you suppose that could be just because more people were staying at home with the orders to stay at home, or what do you attribute that to?
Yeah, it would have been really interesting to find out if the ocular trauma occurred at home, or the types of ocular trauma, because we were dealing with codes. It was either divided into open globe or other parts of the eye. However, one thing that we also thought of was a lot of the private practices in our area had closed during this time, and so patients who may have presented to their local ophthalmologist may not have been able to due to COVID. And so even though we do have more ocular trauma coming in, it may be reflective of other providers who were closed at the time or unable to see those patients.
Mm-hmm. Oh, sure, I could see that. Yeah. Okay. So, when you look at this study, the retrospective study, what in retrospect, I guess, what could be gleaned from this analysis? Do you think?
I think hopefully we won't have to live through another pandemic like this, and it's a once in a lifetime occurrence. But I mean, on the chance that this does happen again, it outlines the fact that you still need to have ocular trauma on call and available, because ocular trauma will continue to present even in the midst of a pandemic with stay-at-home orders.
Mm-hmm.
Not only that, but I think it gives at least a one-center illustration of the types of patients who still need ophthalmic medical care and who will be presenting to your clinics. And so as the supply chain went down and we weren't able to obtain masks and gloves for a while, shunting our resources that we already have to the departments where we know are going to be busy based on the data that we've collected will help academic medical centers, which could be generalizable, to allocate resources appropriately for continued patient care.
Mm-hmm. Okay. And then what, coming out of this, does this help you identify what other areas, for future consideration for additional research? And what might those be?
Sure. Specific to my division, we immunosuppress patients for their ocular inflammation, which normally can present challenges, but in the midst of a pandemic can be fraught with difficulty for a variety of reasons, including collecting labs or even having the patient feel comfortable coming in. And so one thing that the ocular immunology community at large is collecting information about how our patients are faring during the pandemic and any side effects with the use of immunosuppressants with concurrent COVID-19 infection or exposures. So I think this is our projects at least are starting to touch on the impact on patients, and also learning, as we have found out, if delaying care, because patients don't feel comfortable coming in sometimes to see us, if delaying care is causing patients to present later and therefore with further ocular complications of already pre-existing diseases or new diseases.
Mm-hmm. Okay. And I guess I wanted to turn over the other paper you had submitted regarding the resumption of elective surgery. And as you know, in March, the American Academy of Ophthalmology issued their guidelines for urgent and emergent care, and now ophthalmology is beginning to reopen and resume practice again. So what could you talk a little bit about, walk us through the thought process of what some new protocols might be for the resumption of surgeries?
Sure. It's a brave new world, and we are trying to find our way through it as the best evidence-based guidelines are out there. A lot of the guidelines that we do have right now are based off of previous outbreaks from SARS or MERS viruses in the past. And as we are learning data about how long COVID-19 lasts on surfaces, including ones that we use in the operating room, such as stainless steel or plastic, we have to tailor our practices towards that. But the most important thing that we did at our ambulatory surgical center to allow the restart of surgical cases was to test all of our patients for COVID-19 within 72 hours of the start of our procedures, because at our facilities, we do not have negative pressure rooms. It's a different discussion if they are available, as then you can treat patients with active COVID-19 infection. However, in order to resume surgeries that are purely elective in the ambulatory surgical setting with that infrastructure, we have to test them. And also, we've decreased the amount of cases that we do per day to socially both distance the patient from each other by space and time.
Okay. I mean, it's certainly a lot to factor in that we never even imagined that we have to be dealing with right now. So
Yeah.
It's just a crazy world. But yeah, so how is this affecting the different categories or different specialties with regard to how you approach the different procedures?
It's a great question. And because we still are learning about the virus, we know that the risk may be different for the different subspecialties, such as if the patient needs general anesthesia and the need for either a mask laryngeal airway or intubation. We know that the anesthesia needs are different, and we need to have the minimum amount of patients in the room during intubation, and also allow time for others can either enter or exit the operating room to allow air clearance through the HEPA filters. And so general anesthesia, while not commonly used for cataract surgery, more impacts the retina surgeons. And as far as cataract surgery goes, it is believed that there can be some aerosolization from the phago procedure. However, it's felt to be minimal. And one thing that is difficult in front of an operating room microscope is the use of eye protection, because that can hamper your ability to look into the ophthalmic microscope. So there have been a variety of both drapes or shields that one can apply around the ophthalmic operating microscope to protect the surgeon.
Okay. And so what is your overall take-home message from this study that you did?
That so far, and we've been able to operate for about 6 weeks now, we haven't had anyone test positive within our staff or patients, as we do follow them post-operatively via phone calls and a 24-hour line for them to call if they do develop COVID symptoms. And then we obviously screen them when they come in for ophthalmic follow-up for post-op care. So although it's a lot of changes and all at once, they seem to be working with 6 weeks of data to back that up.
Well, that's wonderful. And I wanted to ask you too, like what has been a positive that, as you think back, like over the recent weeks, what has been a really positive thing that is going to influence how you approach the practice of ophthalmology in the future?
I think I have a brand new respect for, not that I didn't before, but a lot more for my own patients, especially the immunosuppressed ones, to have the faith in us that we are continuing infection control and doing everything in our powers in order to provide safe care, both in person and also with the implementation of telehealth, that we can still continue to see them and they believe in us, and that we can continue, despite the demands and despite all the changes, to continue to work with them in order to provide a safe space.
Okay. Well, thank you, Dr. Berkenstock. I really appreciate your time, and best wishes for continued success.
Thank you.